couple of disclaimers. One, I'm not here to criticize or analyze Shakespeare. It's just the name, because we are talking about a discussion about salvage versus amputation, which is not very easy subject. Second disclaimer, there are few bit of a gory pictures or images are there. The learning objectives are, so we have to understand who is the patient, what type of clients is it, what type of injury it is, understand the different variables we will talk about for decision making. It's a very difficult decision whether you will reconstruct a limb or you ablate the limb. There is analyze current evidence, which is, I think, very, very important for this presentation. It is associated with the limb salvage and amputation. And I will talk about a study which is done in US. It's called LEAP study, or Lower Extremity Assessment Project Studies, which is extremely important to take decision about salvage versus amputation. We have to identify factors that influence decision making, as well as usual, economic factor, social factor, and the cultural difference. So, first of all, for this presentation, we have got two scenarios. One is acute injury with a mangled lower extremity coming to the ED or hospital. There is a decision is made in the ED or in the theater whether it will be reconstructed or it will be amputated. There is one scenario. And the second scenario is somebody had an injury 4, 5 years ago, severe injury, multiple reconstruction and salvage procedures done, and at the end there is a lot of problem in the limb, mobility problem, quality of life problem, pain, chronic pain. So now there is an option of reconstruction, or should we ablate or amputate the limb to improve some of the situation. So both are very, very important, but two different scenarios. So I will discuss about this scenario because I'm sure you will be interested to know about this decision making, and it is very, very pertinent for our discussion today. But there are some outcome measures we will talk about which is pertinent for both scenarios. So what is an absolute in limb salvage? I'm not reading it, but it's very, very important. Third line is extremely important because we do see in real life that the clients will probably not remember anything when you discuss at the acute stage of the limb salvage or amputation in the ED or in the hospital. There are usually in mangled limb, there are some discussions about possibility of amputation, whether it's now or in the future, but not always these things can be remembered. But the commonly asked questions are, what would you do if you were me? Can you save my or his or her leg? This is the commonest thing we see. Sometimes it is very difficult to answer these questions at that time. So what are the problems? So the problem is attempting to salvage a leg or extremity without necessary resource, which is extremely. So the hospital or wherever the patient is taken by the paramedics is not resourced. So there is no suitable surgeon or who can salvage or reconstruct the limb. but sometimes it is being tried. So the result is not very good. So I will come to that. Amputating a limb that could have been salvaged into a functional extremity. So it could be reconstructed, but amputated because the lack of experience. Attempting to salvage a functionless extremity. Again, this is very, very important because that causes this. We create disability, we create impairment, more impairment, destitute, breakage of the family, and despaired. So this is all published data in 19, although it's a very old paper, but I think it is absolutely pertinent even today. So attempting to salvage limb that contributes to the patient demise can cause a lifelong tragedy or problem. So what are the variables of this decision making? One is patient or the client himself or herself, type of injury, what type of injury, and medical resource and hospital surgeon. Across the world, it is the same. Is the patient, type of injury, and who is treating. What is the expertise? Where is it, the hospital and the surgeon initially in acute stage? Who is the patient? Can be this, can be this. Two extremes. So we are not ageist, but age is extremely important for this sort of injury and their outcome. Older the age, poorer the outcome. What type of work the patient does, what is type of family support, how Ruby was telling, family, it's not just only family, friends and families. What sort of support and integrity is there in the house is extremely important about the outcome. Recreation or hobbies. What are the comorbidities or what type of mobility? So someone could walk about 10 years with 2 sticks prior to the injury. So we wouldn't expect that he would walk and run the Manchester Marathon after the amputation. It's impossible. Somebody has got a diabetes, for a long-standing diabetes. It's not just recent diabetes. Long-standing diabetes, they will have a peripheral neuropathy and all these things. Motor weakness in the foot. So the other surviving leg will be weaker than expected. So the outcome will be not as expected. And the goal of the person. So injury variables is very, very dependent on the mechanism. So this is a high impact trauma. So whenever we read the notes of the client, there is a description usually from the ambulance service, what type of injury they have seen, and you can guess what type of impact was there for the patient. Severity of the injury is extreme. Again, is no doubt that it is very, very important. I will come to that. And another thing is inventory or injury inventory. So there are different types of elements of a limb. So there is a skin, soft tissue or muscle, bones, arteries, nerve, and the zone of injury. Zone of injury is extremely important. So hand injury is different if it happens here on the finger or on the palm or on the volar aspect of the forearm. So the zone of injury is very, very important for remote outcome. So there is a mangled extremity or the limb complex multisystem injury. There is a thing. So there is a soft tissue, bone, nerves and vessels. So if you have in a mangled injury, you can have a skin and soft tissue loss, which can be repaired with a flap, with a skin graft, with something. We cannot replace muscle. If the muscle is lost, it cannot be replaced, but skin and soft tissue can be replaced. Fracture of the bone can be repaired, can be externally fixed, can be shortened, can be lengthened. Vascular injury can be repaired with our vascular colleagues. They are pretty good nowadays. Nerve injury result is not great at all, even with an immediate repair. So if you look at that, muscle has got, you can't repair. If there is a loss of muscle, it's loss. You can do a rotational flap or a called free vascular flap sometimes. So you are taking muscle from other side with the arteries and you can put it on, but not always in acute setup. The result is not always optimum. And the nerve repair is not well. So third variable is the medical resource. So the familiarity of the salvage technique is important for the treating team and the hospital. There should be a plastic surgeon and the vascular surgeon in the team other than trauma and orthopedic surgeon and patients. So the most of the published data, mostly from the America, they have postulated that it is the level 1 trauma service who can actually, patients can benefit from the repair or the treatment initially at the level 1 trauma service. And that is the reason when the major trauma system started in 2012 in England, it was actually postulated that the patient, even if the level 2 or the trauma care center is nearer to the accident site, the ambulance bypass those and take them to the level 1 trauma service, because ultimately the result is better. So this is the most valid question, isn't it? Is it worth saving the limb at the time? It's very, very difficult to take this decision. It is usually multidisciplinary or interdisciplinary decision, because most of the time patient cannot consent for this. Family members are discussed, but usually it is the treating team. Usually orthopedic surgeon, vascular surgeon, plastic surgeon, eye tube specialist, anesthetist, they all take decision at the time on behalf of the patient. So we ask about this futility of salvage, disservice to the patient, because we have to keep in mind, if we salvage it, what will it offer to the patient in the future? Is it a functional limb or not? And saving a limb may ruin a life. Again, these questions need to answer. Is outcome better after amputation or reconstruction? This is the goldmine question, isn't it? Is there a limb salvage score to help and decide? So yes, there are different limb salvage score. I will talk about a little bit, which are usually used in the acute setup when there is an immediate injury. They mostly cannot be used in delayed cases. There is a nerve called tibial nerve at the back. It supplies the sensation of the sole. If the tibial nerve is gone, usually they end up with some insensate sole. So it's an ongoing debate. If in one of the mangled limb, if the sole is insensate, what will be the result of reconstruction, even if you do a wonderful reconstruction at the immediate time? Does foot involvement change the plan, and what are the financial cost? Last part is not interest. It is not interested to. We are not interested for this part, because when you have an injury, you will treat. But this is more of a research paradigm that you need to do a financial model to find out which one is right to do. Patient satisfaction is again very, very important. Again, at the time of immediate injury, patient cannot consent. Patient cannot tell my satisfaction level is 5 out of 10 in visual analog scale. These are actually retrospectively collected. So we have to think about patient satisfaction in the future. So very, very important. I don't know whether you know about this study, because it was a largest study in the world possibly on mangled limb or lower extremity assessment project, which is called LEAP, L-E-A-P, which is done in the US, which is still acceptable across the world. It was published in the New England Journal. If you want to read, I have the one of copy. You can read it lunchtime. So it is basically outcome of, so they are actually assessing the outcome of the reconstruction and outcome of the amputation in a limb threatening or the leg threatening injury. So this study was done with all the patients, about 601 patients who sustained severe high energy limb threatening lower extremity or the leg injury, where very, very important, where amputation is a serious consideration. So either or, it can be amputated or reconstructed. But it's the number is the sheer 601 people. It's a National Institute of Health funded study. And the most important thing, all these mangled limb studies are retrospective. So later on, we find out the notes and find out what is the outcome. This is a study which they did prospectively amongst 8 level 1 trauma centers. And the tested hypothesis, so what did they try to find out is the outcome after amputation. So they thought before doing the study, so this is our tested, this is the hypothesis, whether it is true or not to find out. And is the outcome after amputation would be better than the outcome after reconstruction for high energy lower extremity trauma after controlling for patient characteristic and adjustment for the severity of the injury. This is very, very important. Patient characteristic we see very, sometimes we do see very difficult patients in the hospital who are not compliant with advice and everything. So their outcome can be worse than expected, as well as the severity of the injury. If this injury severity is extreme, then whatever you do, sometimes all the efforts fail. But this is the hypothesis they thought about it, and they are testing the hypothesis whether it is true or not. There are some literatures from about 1950s. There are a number of literature, but they are all, I told you, retrospective study analysis. They measured the disability, quality of life, and influence on the injured person and the environment. And the results are not, the results are conflicting. So there is no clear-cut inference from these reports. So what did they do in the LEAP study? So they find out all the patients who needed either traumatic amputation. Gastillo and Anderson, there is a classification of open fracture. They took the 3B, 3C, and 3A. So who is 3A? 3A is open segmental fracture, more than 10 centimeter with extensive tissue damage, but very important, where soft tissue coverage is possible. In 3B, it is more than 10, exactly same, but with significant contamination and inadequate soft tissue coverage. So these are the two, contamination and inadequate. And 3C is when there is vascular injury. If there is a vascular injury and it is type 1, it becomes straightway 3C. So this classification, Gastello and Anderson, is again used across the world for any open fracture classification. Why it is so good? Because it actually tallies with the outcome of this. So they only took in the LEAP study the person who had traumatic amputation, 3B, 3C, and some of the 3A open fracture in the leg. Vascular injury means 3C, soft tissue injury, and extra is severe foot injury, which is non-reconstructible. Again, all these patients have got a serious consideration of amputation. Reconstruction, very, very important. Reconstruction typically results in 2-year outcomes equivalent to the amputation, they found out. So they divided that study into 2 years prospective, and then somebody continued it to 7 years. Amazing results. So in the 2 years, when there is a consideration of outcome of these group of clients, it's almost same in reconstruction and amputation. This is very important. It's a bit busy slide, but it's actually, it tells everything about what is the LEAP studies. So they found out an outcome measure, which is the principal outcome measures for this study. No, nothing else. So which is called sickness impact profile, or SIP. So this is an outcome measures about 0 to 100. There are multiple questions, and it is a self-reported questions, but it is so detailed that it tells everything basically when you collect 100 questions. So they took this as the principal outcome measures for the whole LEAP study, nothing else. All other results we found from the LEAP study are like a byproducts. So the more the higher the number, the outcome is worse. Usual population without injury, they have got a 2 or 3 sickness impact profile. More than 10 is severe disability, and it is also can be used for other health condition and injuries. So in 2 years LEAP study, the SIP, or the sickness impact profile for amputation, is 12.2 and reconstruction 11.6. There is no statistical difference. So it's the same. There is another thing they looked at, return to work. Almost 50%, means 1 in 2 that severe injured, lower limb injured patients came back to work. So it's no difference, amputation and reconstruction. So it's amazing result. More the number of the study principle, the more the sensitive is the result. So 600 on 1 patients, amazing results. So they found out some more outcomes other than the SIP and the return to work, and they found this is the result. Rehospitalization for complication in 2 years' time, reconstruction is 48%, amputation, those people who had amputation, is just 34%. Osteomyelitis is more, surgery is more. It's already finished time. So LEAP study is very important, is about long-term result, and with 7-year follow-up, they did the 7-year follow-up. Still there is no difference between groups at 7 years about the SIP or the outcome, but both group worsened eventually with time. Who did worse? Non-white male of this age group no insurance, below poverty line, poor education level, heavy drinker, smoker, poor social support. It's always this group always show worse result in any sort of investigation. So there are some limb salvage index are there for acute limb salvage. There is a mangled extremity severity score, nerve injury component, and mainly limb salvage index, which are used for determining the salvage versus amputation. So this is a tibial nerve injury, which is insensate sole. It's not reliable, it is found, because 55 limb salvage people in first 24 hours after injury had a 26 amputation in this group. It is not reliable, and it is postulated that it is not to be used for amputation criteria only. Financial cost, important. They found it in dollar, obviously. I changed it to with the Google converter in pound. This is the pound in year, per year salvage, and amputation is more. So this is very interesting. Amputation people are costlier than the salvage people, possibly because this has included the prosthetic part as well for their lifelong prosthesis provision. It's quite a bit of difference actually. Patient satisfaction is driven by function, pain, absence of low mood, and return to work. Very, very important. These are patient satisfaction depends. It doesn't depend on injury treatment, psychology, or socioeconomic status. Now, this is the last part. 2 minutes, is it okay? This gentleman had a severe lower tibial fracture, open fracture. This is called pylon fracture. It's the worst fracture because it doesn't heal. Because normally we are born with a less blood supply in the lower tibia and because there is no bulky muscle, there is all tendons and the bones. That's why foot injury doesn't heal, because again there is no muscle. Muscle brings the blood vessels. So this gentleman had an injury, then initially was just temporarily fixated, the fibula is fixed, and as well as a external fixator to keep the limb steady. Then the fixation was changed. Then ultimately there was an ankle fusion or arthrodesis is done, and ultimately this is a modern method of ankle fusion, which is called calcaneal nail. It was done. So 6 surgeries are done for this gentleman. Amazing picture, isn't it? What he is doing now? Next question. Significant problem, poor quality of life, poor mobility, unemployment, chronic pain, low mood, body dysmorphism, hates his leg, foot drop with insensate sole, and non-union at the ankle fusion. So it ticks all the boxes. He can't walk. He just walked two steps with 2 crutches. So this is very miserable situation. So if you see the pictures, all these pictures, they're amazing. So many things are done. But actually the patient is in an awful situation. So bone and MSK issue, soft tissue issue, nerve issue, pain issue, psychology issue, quality of life issue. They sometimes ask for amputation. And even in the lip study, there are some publication which shows that 1 in 3 multiple salvage people, they come back to us in about 3 years' time asking for elective amputation. Because to improve the quality of life, pain, and mobility. There is another thing is a repeat infected total knee replacement. We do get. So Manchester has got 2.9 million population. We see around 10 to 12 infected total knee which land up with above knee amputation in a year. this is our data. So again, which is the best and worst outcome? Because infected total knee is a nightmare. Take it out without knee for 9 months, then put it on, again infected. So this is again. And another contradictory thing is ankle fusion versus transtibial or below knee amputation. So outcome is poor. 2nd and 7 years SIP, so the outcome is same but the complication in the lower in the amputation group, which is very, very important. Consider the whole patient. Shared decision making is important, both with the patient, family members, and the treating physician. Pre-surgery consultation is very, very important, and in larger centers like in Manchester, we have the pre-amputation consultation because everybody wants to scratch others' back. Nobody knows what is right, exactly 100% right or wrong. So it is always better to scratch someone knows about it back to find out a middle part, which is the right for the patient. We do see a lot of CRPS or chronic regional pain syndrome, and in 2012 guideline says do not amputate because it flare up, it recurs. In 2018, there is another recommendation from Royal College where they said in selected cases quality of life could improve, but only time the surgery is done when there is a limb is infected, having multiple blisters and all sorts of things. Otherwise, it's almost always we see at some point, 3 years, 4 years time, it recurs at the stump. Ankle fusion, I was talking about this. So ankle fusion versus below knee is a problem, and we talk about quality of life, pain, and ambulatory status or mobility is the most important. So analyze and see individual patients and find out what is right for him or her. Have I made you more confused? I'm sure I am. Prediction of prognosis is very, very important. Better you are, better is your prediction. And consider the whole patient and always make a shared decision making. Thank you.